Good afternoon, everybody. Welcome to our Lunch and Learn on measles awareness. I'd like to welcome you all and start by acknowledging the traditional custodians and sovereign people of the land across which we work. I can recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I'd also extend that respect to any Aboriginal colleagues who are joining us today. My name's Kira Wright. I'm the PHN immunisation team leader. I'm joined today by my immunisation colleagues, Mimi Campbell and Callan McLeod. Please note that this webinar will be recorded and will be available on the SESFN YouTube channel within the next couple of days. And at the end of the webinar, an evaluation survey will pop up in your web browser. We appreciate your feedback, so please complete this to allow us to issue your certificates of attendance and any follow-up resources. Please ensure that you submit your questions to the speaker in the Q&A function throughout the presentation. We'll aim to answer these throughout the presentation, and any more complex ones we can talk through at the end. Moving on, we've got our annual membership renewals are due soon. Please check your inbox and email us if you have any issues. These are our upcoming events that you can register for. Got a practice nurse networking event at St George Motorboat Club. Practice support can help you with a range of issues, so please contact the practice support email if you need any assistance. Got our National Allied Health Practice Engagement Toolkit is now available, so this is for all allied health providers. My Medicare, some information on that and how to access. And lastly, Health Pathways, always a great tool to help you with your practice. So if you ever have any questions or wondering how to go about a particular issue, please log on to Health Pathways using the code of the patient's address, so Sydney or Southeastern Sydney. Great. I'd now like to move on to our presentation for today. So I'd like to introduce you to our speaker, Dr. Vicky Sheppeard. Vicky is a public health physician who has been working with New South Wales Health since 1999. Vicky is currently the Director of South Eastern Sydney Local Health District's Public Health Unit, and she's also a member of the TGA's Advisory Committee on Vaccines. Thank you, Vicky. Over to you.
Oh, thanks very much, Kira, and good afternoon, everyone. And I'd also like to acknowledge the local peoples and their lands on which we're meeting and pay my respects to Aboriginal elders, past, present, and to Aboriginal people who are with us today. So just looking at our learning objectives. So we're going to look at current measles epidemiology, both in Australia and globally, learn how to identify under-vaccinated cohorts, understand availability and eligibility for free MMR vaccine, assess MMR vaccine needs for travellers, and look at administering live vaccines and finding immunisation histories of patients. So why all the fuss about measles? Well, it is and remains the most transmissible infection, and we use an epidemiological term called the R0, with an estimate that one case of measles can spread to 17 susceptible contacts. Luckily in Australia, we don't have a large group of susceptible people, but nevertheless, it is highly transmissible. Also, measles, as well as being highly transmissible, it has significant complications, which occur in about 10% of cases. So these range from pneumonia, encephalitis, which is about 1 in 1,000, otitis media, obviously probably the most common complication. But there's also one that we don't focus on a lot, which is actual B-cell dysfunction following measles, and acquired immunity to a range of illnesses can be lost following measles infection. And then longer term, there's lifelong complications such as bronchiectasis, hearing and vision loss, and subacute sclerosing panencephalitis, which occurs in about 1 in 100,000 cases. And of course, measles is completely preventable. That's why we're particularly disturbed when we start to see increasing cases. In the pre-vaccine era, it's estimated there are about 2.6 million deaths per year. Mimi, I think you need to go on mute. Yeah, globally, 2.6 million deaths per year before we had vaccines against measles. But even in recent years, there's over 100,000 deaths per year attributed to measles. And probably you've seen in the media that even this year in the US and Canada, there have been deaths, including amongst children and adults, unvaccinated, who've caught measles in the outbreaks that are going on there. So potentially still a very serious condition. Going back, so we first had our first measles vaccine in Australia in 1969, and that was introduced at 12 months of age, but that was just a single dose. In 1992, the second dose was added for the adolescents. So that was in the days when rubella was given as an adolescent vaccine. So that became MMR. But then by 1998, the second dose was moved to 4 to 5 years of age. Then in 2013, the second dose, which then became included varicella, was moved to 18 months of age. And in 2014, Australia had verification of measles elimination, and that's according to WHO criteria, which I'm not planning to delve into the definition, but happy to talk about that if anyone's interested. The two figures that we have here are from the Australian Institute of Health and Welfare. So the one on the left is about hospitalizations, and that's dating from 1994. So in the two vaccine era. So even at that time, there was still quite a lot of hospitalizations per million people, particularly in the under 5-year-old group. So up as far as 250 hospitalizations per year per million population. And that was no doubt some of the rationale for bringing forward the second dose to the 4 to 5-year-old age group. And the figure on the right is, again, AIHW data, and looking at mortality, because that's the only reliable data we had before there was disease notification and good counting of hospitalizations. So there has always been good measures of mortality. So back in the early part of the 20th century, there was up to 500 deaths per year in Australia from measles, which gradually declined even before there was a vaccine. So that would be the contribution of a healthier population, less malnutrition. But nevertheless, even in days when our population was healthier, we were still getting measurable deaths from measles each year. But pretty much since we've had regular vaccination, well, we're not seeing deaths in Australia, but that doesn't mean it couldn't be if we don't manage things properly. So what is the gap? Why do we have a risk still in Australia? So we know that measles vaccine is highly safe and effective. About 95% of people get measurable antibodies, seroconversion, after 1 dose of vaccine. And the reason we give 2 doses is to pick up those who didn't respond to the first dose. And we're up to around about 99% protection after 2 doses. And that immunity is probably lifelong, provided, absence of bone marrow transplant, etc. So either having acquired the disease or having 2 doses of vaccine, one can assume the rest of the lifetime the person would be immune to measles. And the World Health Organization recommends a population coverage of 95% vaccination of each annual cohort to reliably eliminate measles. So we do have an immunity gap though, and particularly in our birth cohorts between 1966 and around about 2000. So there's a number of factors that contribute to low immunity in these age groups, which are now around about 60 to their early to mid 20s. So because vaccination started in 1969, there was less exposure to the wild virus. So people born from about 1966 in Australia were less likely to catch measles. And there was also variable uptake of the single dose. We didn't have a pretty robust national immunisation program like we do have now, and certainly no national register of vaccination. So it was pretty easy in those days to slip through the cracks, and when there was just one dose, it wouldn't be unsurprising that families might miss it through various circumstances. Even those families who say their children received all their childhood vaccines. And then, as you saw on the previous slide, the 90s were a bit of a confusing period in that the vaccine was first introduced in the adolescent years and then brought forward to 4 to 5 years. There was a high school or all of school catch-up program. But because of those changes and people, it always takes time for both providers and the community to get used to a new schedule. So many people born in the 90s also didn't manage to get 2 doses of vaccine. So in summary, people aged about 25 to 60 may be susceptible to measles. Just spend a little bit of time looking at the disease. So measles is transmitted by aerosol, by droplets or fomites. And the aerosol transmission is most troubling in that and one of the reasons for its high transmission rates is that it can last in the air for a couple of hours after someone who's with measles has been in the room. So there may be no direct contact between the sick person and susceptible contacts. The incubation period, so from exposure to onset of symptoms, is between 1 and almost 3 weeks. So it can be quite a prolonged period so that people may have forgotten about an exposure by the time they develop symptoms. And the disease starts with a prodrome, so usually a fever, usually greater than 38 degrees, and the 3 C's, cough, conjunctivitis, and coryza. So the figure in this on the right is using from the US, so it's got temperatures in degrees Fahrenheit, but normal temperatures, the dotted line. So it starts with the first symptom is fever, which rises gradually over several days. And then the next thing that appears is conjunctivitis, coryza, runny nose, and a cough. Can be followed by cochlear spots. We'll have a look at those in a sec. And then the 3rd or the 4th day is when the rash develops. And you see throughout this time, fever's present and doesn't effervesce until after the rash has appeared. So the rash starts on the head, then spreads to the trunk and then the limbs. And fever is invariably present at the onset of rash, and that's a very consistent presentation of measles, having fever at the time the rash emerges. The cochlear spots can be seen on the buccal mucosa and red background and little white spots as can be seen in the picture here. White spots on a red raised background. People are considered infectious with measles from 24 hours prior to their prodrome. So once again, another trick with measles, people are infectious before they have symptoms. and people are considered infectious until 4 days after their rash appeared. So all in all, can be up to about 9 days that people are infectious with measles. So just a couple of pictures. This is a pretty classic baby. You can see the rash on their face, spread to their trunk and their limbs. Looks pretty miserable, which is also a feature of measles. On people with darker skin, the rash may not be quite as easy to discern, but still a blotchy and widespread rash. So, who might have measles? Who's susceptible to measles? So, the first group is infants under 12 months of age. So, particularly from around about 6 months up until they've received their first dose of MMR, which is due at 12 months. So, the first 5 or 6 months of life, infants usually have persistent passive immunity from their mum. But of course, if the mother's susceptible, then the infant would be susceptible from birth. As we saw a couple of slides ago, we consider anyone who's up to 60 years of age, so born during or after 1966, if they don't have documentation of 2 measles vaccine doses. Now, that algorithm that we use up between 25 and 60 is based on our Australian situation and the changing epidemiology. So people who are born and lived many years in other countries, they may have differing susceptibility depending on their local epidemiology. So we really have to judge that on a case-by-case basis. And of course, people with immunocompromise. So whether that is due to significant immunocompromise from medications or acquired conditions, they may well have lost any previous immunity to measles. So that's the susceptibility side, but who then might have measles? Well, on top of susceptibility, one has to be exposed, of course, to get the disease. So relevant exposures would be overseas travel during the incubation period, so the past 3 weeks. Visiting a known exposure site in Australia in the past 3 weeks. So I will talk a bit more about that in a while. And of course, known contact with a measles case. So we're in assessing the likelihood of measles, we're looking at both the person's susceptibility and what their exposure to measles is. So responding to suspected measles, so someone with susceptibility and exposure, we'd really like that you isolate them, test them, and call the public health unit. And this is just one of a range of posters that are available on the New South Wales Health website that can help alert your patients about symptoms and what to do. So measles management. So how to isolate suspected cases. So one way to do it is to try and see them at the end of the day when other patients not around. And definitely don't leave people with suspected measles in the waiting room. And that's why it's great to have some posters up in case they haven't alerted staff ahead of time, trying to prompt them to make their potential diagnosis alert to the reception. And if someone is coming for suspected measles, not leaving them in the waiting room, give them a mask and put them in a room. If you have seen someone with measles, you think it's suspicious, leave your consultation room vacant for 15 minutes afterwards. Otherwise, if other patients are brought into that room because of the risk of aerosol transmission, they would be considered contacts and need contact assessment. and counsel a patient who you suspect might have measles to stay at home while they're awaiting test results, or if that's confirmed, until they're no longer infectious. So the testing. PCR is really our mainstay of diagnosis in the acute phase. So, and preferable to get both a throat swab and a first pass urine to order for measles PCR. Serology is useful in some cases, and I've got another slide where we can talk about that more. And the other thing is potentially excluding other causes. So things like adenovirus, influenza, enteroviruses, other viruses that can cause fever and rash. So it's good in some, if the person doesn't have that, the high suspicion for measles, both the susceptibility and the exposure, then on the PCR, ordering other causes of fever and rash. And by all means, we'd really welcome a call for you to talk through what you're seeing, and if it's highly suspicious, so that we can expedite the PCR testing, because the sooner we can confirm it, the quicker then we can get on to protect other contacts. So this is just some of the considerations for the use periods for the different tests. So prior to rash onset, up to 3 days after, the PCR is definitely the preferred test. Now, serology might be useful in an adult, for example, who has an uncertain vaccination history. And if you can show that they already have IgG, then measles can pretty much be excluded at that stage. Once it gets to 4 days after the rash, the PCR can still be useful and it can still be positive out to 2 weeks. But this is where serology comes into its own, and having an IgM is almost certain to have be detected by 4 days after the rash. So then that's the more preferred test later on in the illness. And then the other situation that does arise not uncommonly is in infants who've been recently vaccinated and they present back with a fever and a rash. And it's a matter of distinguishing whether they're having a vaccine reaction or they have also been unlucky enough to be exposed to measles. And I certainly can recall we've had circumstances of infants who've been exposed to infectious cases while they were in the waiting room waiting for their MMR vaccine. And then a week later, they present again quite sick. So we need to be able to distinguish whether this infant is having a vaccine reaction or they've got measles infection. And really the only thing we can do there is the PCR, and all the reference labs do have a PCR that can distinguish between wild virus and vaccine virus. And of course, in that circumstance, serology is not useful because that would be developing an IgM response either to the vaccine or the disease. Okay, so once measles is confirmed, what's the next steps? So for the patient management, as we said before, the patient should be isolated until 4 days after the rash appears. They may still have persistent rash and symptoms at that time, but then don't need to be isolated any further. The mainstays of managing the disease are managing the fever and the hydration, and then also monitoring for complications. And just using this same figure again, you can see that after the rash appears, the fever quite rapidly effervesces and is very minor. So if pneumonia or otitis media are going to develop, well, then you might well see the fever going up again. So that's when we need to get them assessed for bacterial complications of measles if the fever recurs after about 5 days of rash. And the contact management, which you would be guided by the public health unit on. So we'd be identifying susceptible contacts in your practice, but also in the community, school, childcare, wherever the person had been. MMR vaccine is very useful up to 72 hours after exposure to prevent developing measles infection. And for those who are really high risk, we will use immunoglobulin up to 144 hours, so that's 6 days after exposure. And that's really reserved for susceptible pregnant women or people with severe immunocompromise or infants. We wouldn't use immunoglobulin more broadly than that. And just a reminder to ensure that all the practice staff are immune to measles. So everyone working in your practice, reception, nursing, GP, allied health, should all have 2 recorded doses of MMR, because we don't want them caught out in this situation of being susceptible if a person with measles comes in. So moving on now to the measles vaccines, I'm sure you're all very aware of the routine schedule of MMR at 12 months and MMR-V at 18 months. But vaccinating on time is a really important thing to do, because the sooner we can have our babies and toddlers immune to measles, the better for them. But, catch-up is also a really important thing that practices can be doing. So everyone born during or after 1966 should have 2 documented doses of measles-containing vaccine. So, and the documentation is important there, really important that it is written somewhere, either in the Australian Immunisation Register, Blue Book, patient-held record. Someone from overseas could have some other kind of record, but we want to see 2 doses of measles-containing vaccine at any stage in their life. So you can use MMR-V up to 14 years, and that's funded under the National Catch-Up. And similarly, MMR up to 19 years is also NIP funded. But then in New South Wales Health funds everyone once they've reached 20 years of age up to 60 for free MMR vaccine if they don't have 2 documented doses. And if no documentation is available, then it's safe and recommended to give a dose of MMR. So no need to do serology. It is such a safe vaccine that it's cheaper and most effective and efficient to just give a dose if there's no documented doses. Of course, there are some precautions. Measles, all the measles preparations in Australia, they're live attenuated vaccines, so definitely not to be given during pregnancy or to people with severe immunosuppression. And the Australian Immunisation Handbook was just updated earlier this month with a really, really useful table that distinguishes mild, moderate and severe immunosuppression for both acquired and innate immunocompromising conditions. So that's the place to go to understand whether or not your patient is considered to have severe immunosuppression, in which case they shouldn't receive any live vaccine. You can give MMR at the same time as other live vaccines, or if it's not given at the same time, you need to wait 28 days. So for example, in a traveller, if they've had a yellow fever vaccine, you can give measles, MMR and yellow fever at the same time, or they have to be separated for 28 days. And there's also varying delays recommended following blood products. So if in a measles response, we give normal immunoglobulin as prophylaxis, then there is, I think, a 5-month wait to be then receive the vaccine. So it varies depending on the blood product. And again, the Australian Immunisation Handbook has comprehensive information on what kind of delay is necessary for which blood product and live vaccines. So moving on to the current situation, and a common quote is that measles anywhere is a threat everywhere, and particularly in our world today with such very frequent and efficient international travel, it's absolutely super easy to have measles spread around anywhere around the world. Now, those dark blue blots are places where there's currently quite high measles transmission, and this graph is just, I think, a little bit, perhaps a few weeks out of date, because now the US and Canada have both also had more than 1,000 cases of measles in the past, during this year. So we can see North America, including Mexico, is a high-risk area. Obviously, Russia, China, Korean Peninsula, India, Southeast Asia, Indonesia, Philippines, and also parts of Africa have had quite high measles cases reported this year. On the right is, so Yemen has the most, followed by Pakistan, India, and Afghanistan. But, you know, our neighbours and popular tourist destinations for Australia, Thailand, Indonesia, plus also Vietnam, also have lots of measles activity. Australia's in blue there. We'll look at Australia in a second. And this is just showing measles cases back over the past 8 years. So you can see pre-pandemic in 2019, there was 500,000 cases at that time. They were mainly in Africa. So we weren't as impacted in Australia. We have less tourism and travel between Australia and Africa. And of course, during the pandemic shutdown, measles was pretty much contained by other public health measures. But since then, we have had an increase. Europe certainly saw a lot of cases in 2024. And 2025, I think the difference for us is we're seeing more cases in Southeast Asia and the Western Pacific, which is our region, and so also more of a risk for us than probably Europe and Africa. So these are Australian notified cases in the past 10 years. We've had 77 cases so far this year in Australia. You can see that our trends do somewhat mirror the rest of the world. So we did have a peak in 2019, obviously mainly brought back from overseas travellers at that time. Very few cases reported in the pandemic years, but quite a lot last year and this year. We're seeing a number of introductions, but in Victoria, which is the yellow line, there is ongoing transmission in Melbourne. So Melbourne's continuing to see cases. And there's also been, Western Australia is also having an outbreak this year. I think more related to in jail, people who are in the jail system there. And this is New South Wales, the blue line. We have had a couple of transmission cases, but no sustained transmission in New South Wales this year. And these are over that same 10-year period in Australia, the notifications by age group. So you can see that those under 5 is a large number of the notifications, but actually very similar to the numbers in young adults. So that's 20 to 29 is another big risk group for us. They've been susceptible to measles, and plus they love to travel. I think the other remarkable thing, which really confirms what I was talking about before about susceptibility, you can really see almost an absence of cases in people over 60 years of age. So that's a testament to the epidemiology we were speaking about before, and that people born before 1966 are almost invariably immune to measles. So, routine vaccines for travel. So I do have another presentation which I've given, which includes about travel vaccine, where we talk about the 3 R's. So the routine, the recommended, and the required. So MMR is top of my list for routine vaccines for people who are planning travel. You can see the other ones there: flu, COVID, tetanus, and maybe Hep B. But MMR, I'd really hope it's at the top of your list as well, if people are coming to see you prior to overseas travel. So important, particularly assessing infants for travel, and with our population, it's not at all uncommon to take small infants overseas. People who are from overseas backgrounds love to take their babies back to visit family and friends, and others find it's a great time to travel before baby gets too much of a mind of their own. So really important thing to think of if your families in your practice are thinking about travel and they've got a new baby. So the things to weigh up are the measles risk at the destination. So if someone is traveling, I would suggest to places like Vietnam, the Philippines, Thailand with their baby, and also potentially to some destinations in the US and Canada. Their outbreaks are a little more circumscribed to Texas and I've forgotten the part of Canada, but rather than being widespread all over the country, they're more circumscribed. So, you know, what's the risk of measles at the family's destination? Certainly looking at the current recommendations on the New South Wales Health website, and also looking at the infant's age. So generally under 6 months of age, as we said before, we can rely on passive maternal immunity, and vaccination is not recommended at all under 6 months of age. Between 6 and 11 months, our current recommendation is to give MMR vaccine pre-travel. So by 6 months, the maternal immunity will have completely waned, so they're fully susceptible. MMR is a safe and effective vaccine under 12 months of age. It just doesn't produce the prolonged immunity that we see when we give it at 12 months. So in some countries, it is routinely given at 6 months of age. Here, we would, if a vaccine was given pre-travel under 11 months, then the schedule at 12 and 18 months should be resumed on their return. So they would receive 3 free doses of MMR vaccines. The pre-travel dose is funded by New South Wales Health. Once the infant, if you see them and they've already turned 11 months of age, then give the MMR vaccine pre-travel, and that counts as their first dose. So that's an acceptable time for the first dose. If they've turned 11 months of age, doesn't need to be repeated, and then just give the 18-month dose on schedule. All right. So a couple of travel scenarios, and here we've got some polls for you. So first off, so we have a 24-year-old female. She comes in 3 weeks before her travel to Vietnam, so kudos to her for coming in early. What do you need to know? I don't have a poll for that one, but the usual pre-travel questions. What are you doing during your travels? Are you staying in high-class accommodation? Are you going back of bush? What kind of activities are you doing? How long will you be there? And other regular medications that we need to think about. So just the standard questions. But this poll relates to the second question. Where can you find her vaccine history? So there's a few options there. So if you can see the poll, I don't know if I can see the outcome of the poll, can I?
I was still letting it run, but I'll end it now.
Okay.
And share the results.
Very good. Okay, so yes, the heir, a 24-year-old, so they were born in 2000, 2001, so the heir should have a complete record of her vaccinations because it started in 1996. Blue Book is also a very valid place to look. And a patient-held record. We don't know where she was born, so she may well have official record of vaccines from another country. Now, asking parents, I wouldn't at all rely on that. And as we need to see documentation of measles doses, parents might be able to tell us where to look, but that's not something to be relied on to determine if she is immune to measles or not. So the next question is, which vaccine do you offer? Just 2 choices there. Noting she's 24. So assuming that there's no documented history of 2 doses, which vaccine do you offer? Great. Yes, MMR is the correct choice. MMRV is only registered up to 14 years of age and is not funded at all for catch up over 14 years. And then finally, is there any cost? So she's 24, she has no documented doses of measles. Is this NIP funded? Is it state funded, or does she have to go and pay for the vaccine herself? Very good. The majority is correct. So she definitely doesn't have to pay. No one in New South Wales needs to pay for any MMR vaccine. But over the age of 20 and over, it's a state-funded source rather than NIP. From your perspective with your state vaccine in the fridge, it's not really distinguished. But certainly we wouldn't be asking anyone to be paying for MMR vaccine in New South Wales. We don't want to have any barriers to people being vaccinated. All right, so this time, and I hope I'm not being gender typing here, the 45-year-old male comes in just 1 week before his travel to Thailand. he's just going to Bangkok and staying in fancy resorts. He's got no adventure trips and he's otherwise well. So in general, his travel risk is low. But MMR being the top of your routine vaccines before travel, you try to find out about his vaccine history. So where do you think you might be able to find his vaccine history? Same options as before, the AIR, the Blue Book, parent-held record, or ask his parents. Sorry, patient-held record. Should have some thinking music. Okay, so this one is a little more difficult. Someone who's 45, so they're born in 1980, they're unlikely to have measles vaccines recorded in the air because it would have to have been an adult vaccine received after 2016. So it wouldn't be surprising not to find anything in air for a 45-year-old. He may well still have a Blue Book or some other patient-held record that could provide evidence of measles vaccine doses. But of course, born in 1980, he's very likely, unless he's specifically caught up in the past, he would have only been offered one dose, even if he received all his scheduled childhood vaccines. And once again, asking parents, that might help us where to look, but we certainly wouldn't rely on any parental or other verbal history of measles vaccine. We really need to see a documented dose of measles vaccine to rely upon. So what would you do if you can't find any written record of 2 doses of measles vaccine? So the options you could give MMR, you could address the situation on return from Thailand, or you can take serology, noting that he's leaving in a week. Great. I agree that just giving MMR now is the best thing if there's no documentation of 2 doses. I wouldn't want to wait till he returned from Thailand because he might come back with measles. And serology, you might want to take that at the same time as you give the vaccine, but you may not get a result plus have time to vaccinate him. You've only got a week. And as I said before, the vaccine is safe and effective. It's free, as opposed to serology, which is not free. And even if he has had 2 doses in the past, there's no harm, and we strongly advise just vaccinating him. And finally, is there any cost? And we've already done this once before. So let's see how we go. That's great. 100% correct. So for a 45-year-old, it's no cost, and that comes from the state-funded vaccines. Terrific. All right. So I'm just going to wrap up now, and then we can address any questions. So key actions for primary care. We keep our prevention going, vaccinating infants on time at 12 and 18 months. Try to proactively check all patients under 60 years for their vaccine history and catch up as needed. That could be a QI activity, but particularly prior to travel, double check that they've had 2 doses of measles vaccine, and always be thinking of infants under 12 months if they do need to have an early vaccine. And then in case all our prevention fails, being alert for fever and the 3 Cs, cough, coryza, and conjunctivitis in returning travellers. And then if you're suspicious of measles, someone's got susceptible and exposure, please call the public health unit for help and advice, and we'll work together to manage the situation. So just reinforcing the learning activities and learning outcomes, I hope that you now are able to describe the current measles epidemiology, both locally and globally, identify under-vaccinated or susceptible cohorts, understand the availability and eligibility of free MMR vaccine funded by New South Wales Health and the NIP, assess MMR vaccination needs for travellers, including infants, explain the key considerations for administering live vaccines, including the timing intervals and the contraindications, and locate immunisation history using available tools and describe appropriate actions when documentation is unavailable. So there are the resources, the New South Wales Health landing page, the Australian Immunisation Handbook, and I'll add the immunocompromised to that in the chat, and health pathways, of course, depending on which district you're in.
Amazing. Thank you so much, Vicky. That was very comprehensive, fundamental understanding for what we need to know about measles. I hope that answered a lot of the questions that you might have had or some queries that you might have. But please, if there are any more questions, put them into the question and answer box now and we can ask Vicky live. We also have been putting together a little resource sheet in the background with everything that Vicky's mentioned, so we'll share that with everybody after the session. So we'll include the Q&A, the answers that have been provided so far by Mimi, who's been working in the background to answer some questions as well. But I guess we can just reinforce these Q&As by talking about them now, Vicky. So one question here is, I have a patient in her early 20s who has had 2 doses as a child in Australia, but the serology has come back not detected. She's a student nurse going to Philippines for volunteer work. Do people with no serology but have 2 doses need another one?
No, and in general, we discourage, and the handbook discourages doing serology. We rely on the documented doses rather than serology. But in that circumstance where you do serology and it's not detected and going to a really high risk place, such as the Philippines, it's certainly wise to give another dose. I mean, as we said, 2 doses, 99% of people will seroconvert, so she may be that 1% who didn't. Hard to know. So I guess in that case, it's good to have found out and to give another dose, but we certainly don't recommend continuing to check for a response. No more serology.
Great. Thanks, Vicky. Another similar question, but opposite. So the patient was born between 1966 and 1994. They've had 1 dose as a child. And then do they still need another dose if they do have positive serology?
Yeah. As Mimi's put in, yes, we wouldn't normally recommend it doing the serology. So from a measles perspective, they are considered immune. But we've also got to be thinking about the mumps and rubella, particularly the mumps. So yeah, if you've got documentation of IgG of all those 3 conditions, no, they don't need to have another dose.
Great. And I think this question came up as you were talking about diagnosis of measles, but does it have to be a throat swab? Can it be nasopharyngeal swab?
Yes, yeah, for infants, that's certainly acceptable.
Excellent. And just to clarify, anyone born after 1966 with or without Medicare, are they eligible for 2 free doses of
Yes.
MMR?
Yes.
Yeah, so just to confirm, no Medicare card is required. If you don't have those 2 documented doses, then yeah, give them the free state-funded MMR.
That's right. We don't want measles in New South Wales.
Yes.
It's a small price to pay to prevent measles.
Exactly. And I guess just to clarify as well, some people have some questions that I've experienced in the past. So the NIP funded, which is the national funded program, has catch up for up to age 20. So once you turn 20, you can no longer receive catch up state of as the NIP funded. So after you turn 20 for MMR, that is a state funded dose or
Yep.
doses if required. So I know just because with air recording, you do sometimes you have to put in, if it was state funded or nationally funded. I do believe that air are getting rid of that requirement because it did confuse a lot of people. But if it does ask, yeah, that's how we would explain that in that
Yeah.
situation.
Once you're in New South Wales, it doesn't make a practical difference. It all comes out of the same fridge. But if a practitioner is moving from state to state, that just needs to know what the state's criteria are. So there's a question there about SSPE. Yeah, it's about 1 in 100,000. And it's only from wild measles infection. It doesn't arise from vaccine infection at all. So with the very small numbers of measles cases we've had in Australia in the past couple of decades, you probably never will see it. But it's a very slowly progressive. I mean, I think it initially can present up as early as 5 years after infection, but it can present a decade or so later, and it's really like a slowly progressive dementing type presentation, and unfortunately, it's invariably fatal. So people over 20, 1 or 2 doses, depending on what's already documented. If they have 1 documented doses, give a free second dose. If they have no documented doses, give 2 doses, at least 4 weeks apart.
Yeah, and that got a question here from regarding air uploads as well. So you do not need to have a Medicare number to be able to have an air record. A health identifier is helpful, but again, it's not necessary. Air can have a record purely off a first name, surname, and date of birth. So always upload every vaccination given to a patient.
Yeah.
Great. Yeah, well, I guess with 1 minute to spare, we'll wrap up here. And as I said, everything that's been discussed today, we'll put together on a resource sheet and share that with all the participants after the fact. And also, please share this recorded YouTube webinar once it's available with all your health providers that may have missed today's session. And ensure that every patient that comes through your door that's born after 1966 has 2 documented doses of MMR vaccine. Thank you, Vicky, for joining us today and for your comprehensive presentation. And just a reminder that an evaluation survey will pop up at the end. So please fill that out to help us in continuing to provide timely education sessions. All right, thanks everybody. Have a great rest of your day.
Thanks, Kira. Bye, everyone.
See you.